Dear members of the European Society of Coloproctology, the monthly topic for December is pilonidal disease. The mechanism by which a pilonidal sinus originates is still an enigma. The entrance to a pilonidal sinus is one or multiple pits in the midline. It has been suggested that these are enlarged hair follicles. However, any other midline nook or cranny could suffice. The progression to pilonidal disease is currently thought to be an acquired condition in which loose hair enters a pit in the nasal cleft, causing a foreign body reaction resulting in abscess formation. Hairs are present in the pilonidal sinus in 93 to 100% of patients with symptomatic pilonidal disease. It has been proposed that the hairs enter these midline pits by their roots, driven by their distally directed scales, which also prevent their retraction. In 1955, Wheel was the first to describe the parallel course of hairs with roots first in 7 patients by serial section of the pilonidal sinuses. As a proof of principle, in 1969, Page placed 2 hairs into a primary opening and asked the patient to walk around for 30 minutes. The picture on the left shows 2 hairs engaged in the mouth of the sinus at the beginning of the experiment. The root end of the knotted hair and tip of the other hair are engaged. The following photograph is taken half an hour later, the patient having walked about in the meantime. The knotted hair with its root end has worked its way into the sinus. The other hair has been migrated out slightly. In 1984, using light microscopy, Stelzner identified the scale architecture of the loose hairs obtained from the pilonidal pits. He suggested that because of this scale structure, movement is only possible in one direction. This scale configuration of hairs in the pilonidal sinus was confirmed using a scanning electron microscope by Dahl et al. In 1992. Our group assessed the orientation of the hairs in the primary pilonidal pit by scanning electron microscopy in 17 patients with pilonidal disease. The hair was found to be orientated with its root end into the pit in 15 of the 17 patients. Here you can see 4 scanning electron microscope images showing a hair orientated with its root end into the primary pit. The principle behind this phenomenon can be nicely demonstrated by taking a hair and rubbing it between your finger and thumb. You can see the hair moves in one direction. Turn the hair around, and it moves in the opposite direction. This rubbing represents the friction in the gluteal area. Recently, Doll and co-authors studied the hairs of 17 patients with pilonidal disease using an electron microscope. They found that most hairs were rootless fragments with sharp cut ends, as illustrated in this figure. The authors hypothesized that these needle-like sharp ends of the hair may contribute to the hair piercing the skin and resulting in pilonidal disease. This could also explain the occurrence of pilonidal disease between the fingers of barbers. However, we noticed that the scales on the hair used in this illustration were facing the wrong direction according to our findings, as mentioned before. These authors also found that the physical properties of the hairs in the pilonidal sinus were identical to occipital hair. Therefore, they suggested that pilonidal sinus disease is promoted by occipital hair. However, in our experience, short hairs are the most common within the sinus. The sizes of hair after a barber cut are much more variable. We found similarities in shape and size of the hairs present in the pilonidal sinus when compared to hairs from the buttocks. Nevertheless, the literature on razor depletion or laser-induced depletion of hair in the gluteal area is inconclusive. However, local razor hair removal during or shortly after surgery seems to increase the rate of recurrence. It is probable that these razor-sharp ends may intrude into the wound area. In conclusion, the most consistent finding in pilonidal disease is that of loose hair with its root end in the sinus. Hairs shed from the buttocks or elsewhere migrate to the cleft where they enter the pit by their roots. The orientation of the scales probably prevents expulsion of the hair and encourages the hair to be driven deeper into the pit and eventually into the subcutaneous tissue below, where the foreign body reaction creates the pilonidal abscess. Healing will not occur until the hairs are removed from the pilonidal cavity. Therefore, we believe that the management principles of pilonidal disease should be based on removal of hairs from the pilonidal cavity and avoidance of future potential ports of hair re-entry. Application of these principles preferably should be applied with the least invasive techniques possible.